Okay, welcome everybody. I'm Dr. Shanti Kulkarni, and I'll be one of the co-presenters today along with my colleague, Dr. Kelly Powers. I'm just going to introduce myself real briefly, and then Kelly will kind of take over, and then we'll kind of tag team a little bit as we go through this presentation. So I'm a professor of social work, and the way I became involved in interprofessional education is through a HRSA grant that we were awarded about 4 years ago. And the purpose of this grant is really about training social workers to provide integrated behavioral health services within primary healthcare settings. And through that program, Kelly and I have begun to do a lot of collaboration around between nursing and social work, and also joined with other professions through the medical school. And we'll talk about that a little bit more as we get into the presentation. The other thing I want to just mention as part of context is this advancement towards interprofessional care is something that is coming from all of our professional bodies. So for example, the Council of Social Work Education now has competency standards around when we graduate students, we want them to have those competencies to work with other professionals, and that's all happening across the different professions like public health and nursing and medicine and pharmacy. And Kelly will talk about that as well. So welcome, and we're looking forward to spending this time with you.
Hi, everyone. My name is Kelly Powers. I'm an assistant professor in the School of Nursing at UNCC. And as Dr. Kulkarni said, we work together on a lot of interprofessional education initiatives, and it's grown into a passion for both of us. So we're excited to share this content with you and to stimulate some discussion around IPE and ways to move it forward. So we've been doing projects through the HRSA grant that Dr. Kulkarni's lead on, and we've published our work. We've done work on in trying to get interprofessional education in innovative ways, online, using simulations and all of that. And so we're excited to share what we've done, talk about IPE in general, and get the discussion going. So I'm going to share my screen now and get going. Can you see my screen? Okay, great. So the title of our presentation is Addressing Social Determinants of Health Through Interprofessional Education, which is also called IPE. So either one's going to come out of our mouths, just so you know. So IPE is interprofessional education. And we worked really hard on the design of this PowerPoint in making sure that it shows that as co-authors of it, co-presenters, that we're synergistic, collaboratively working together. And that's the representation of those circles there. There's no hierarchy. We collaborate to work together and bring you this presentation from a perspective of both of our professions, which is really key to successful interprofessional collaboration. So I need to move your heads. I'm sorry. There we go. Okay. So due to a variety of factors, the changes that we've seen explode in healthcare. We have increased acuity of patients, more chronic diseases, increased complexity of care. Couple that with fragmented systems and fragmented transitions of care, moving from one setting of healthcare to another, seeing multiple different specialists in all of these fragmented areas, along with a recognized need to address social determinants. Due to these factors, healthcare has to be performed by interprofessional teams. Current healthcare professionals must shift to a team-based care approach. And graduates, our graduates from undergraduate programs and graduate programs must be prepared to effectively work in teams. The problem is that despite knowing this, practice and education continues to occur largely in professional silos. So we're going to start off here with a poll. Wanting to know which of the following best describes your work site. So you should see a poll pop up. Okay, so the results show that really indicative of how healthcare is. Nobody selected one, saying that we work as just one profession in our site. So that's just not the way healthcare is now. Healthcare needs to be from a variety of angles and different professions, different perspectives, different um, specialty areas, different talents. So that's good. So that's consistent with what healthcare is now. But you can see here it's kind of split. Um, about half of you have persons from various professions, but mostly work independently and only consult each other when necessary. And the other half are going more towards the extreme of really doing shared decision making as a team, as an interprofessional team. So we have people here maybe wanting to learn more how the shared decision making can be implemented in their setting. And we have some people here who are already doing that, maybe want to share their expertise and even think of ways to do it better. So thank you for doing that. I'm going to move to the next slide. Maybe. And one more poll here, poll 2. We want to know how often interprofessional team-based care is practiced at your work site. So as a team, not just consulting. Great. So thank you, everybody. So a few rarely or don't practice. The majority of you sometimes practice this, and one of you usually practices this. So we're seeing that, we know interprofessional team-based care is good to do, but it's clear that we still have work to do within our work settings. And that's true for academia, that's true for practice, that's true all over, that we still continue to work in silos. We're getting better at approaching the team-based approach, but we're not quite there yet. We still have work to be done. I'm going to stop sharing this and move forward. So why do we need to focus on interprofessional team-based care? Well, the effects of continuing our siloed approach to care and education is that patient safety suffers. Right now, healthcare errors result in more than 250,000 deaths per year among adults in the United States alone. Prior to the pandemic, it was recognized as the third leading cause of death in the United States. The root cause of about 3/4 of these errors is communication failures within and among different teams. So different persons, different professionals within a team not having proper communication, and then not following through to the other team, and communication failures there too. And these figures are astonishing. Some reports quote that it's probably upwards of 400,000 deaths per year. And this is just deaths, not injuries, not adverse events. And it's also just focused, it's not focused on quality of care. If we don't have an interprofessional team-based approach, we're not going to have comprehensive care. And this results in inadequate care of the persons, families, and communities. So for example, if we use the medical model only, we're going to have missed opportunities for mental health and social care. Addressing the social determinants of health clearly requires a team-based approach. It cannot be a medical model only. We have to move it forward to have comprehensive teams to meet our patients' needs. If we don't do so, if we continue to have a lack of comprehensive care, if we have fragmented care, if we don't use a team approach, what happens is our patients, our communities, families, they experience things negatively. They experience healthcare negatively. They develop frustration, they develop mistrust, and what happens is they no longer access care, and we lose opportunities for prevention and improvement of health outcomes. So for example, if you are going into a clinic to be seen for whatever reason, and all of the different professionals approach you at different appointments, or they come in separately, and you have to repeat your story, maybe it's a traumatic story, you have to repeat it several times over and over, what happens in your head is you're like, well, this team's not communicating. This team isn't pulling it together. They don't know what they're doing. I'm not doing this anymore. And that's where we can see the breakdown in quality happen. Not just errors, but quality suffers and missed opportunities for really giving comprehensive care and improving health outcomes. We also see a negative effect on our graduates and on our health professionals. We see if there's not a positive team-based approach to care, we see poor transition to practice retention rates. I'm a nurse, so speaking from nursing, I know this is a huge problem for us. We lose 25% of new graduate nurses leave their job within that first year. We already have a huge shortage of nursing. We cannot afford not to retain these professionals. And that's just from nursing. I know it can be a problem in other professions also. We have high rates of burnout, even higher than they ever were because of the pandemic. These high rates of burnout from, not having a team atmosphere, not having a positive work environment, having too much stress, performing errors, and the negative effects that has on the person leads to burnout. And people either leave the profession, leave their job, or they have a negative outlook on their job, which affects the other staff, or all of those affect the other staff around them. And then we have to look at the health outcomes of our care providers. Yes, we want to improve health outcomes of all of our patients, our families, our communities. We can't forget the health outcome of our community of healthcare providers. Again, magnified so much worse due to the pandemic and the stress that all of our healthcare providers went through. But even before that, we've known for years that there is a high suicide rate among physicians, especially those in their residency. We finally have documentation coming out about the rate of suicide being higher in nurses than the general population. We're in a stressful profession, and we need to create positive team-based environments to work in. So we're going to just talk for a minute before we move on to IPE. Dr. Kulkarni and I wanted to share a video that we utilize in one of our classes to really stimulate discussion on why interprofessional teamwork is important, and especially why communication is so important. So I'm going to hit play here, and you should be able to see it and hear it.
Corner socket. Corner socket.
Quarter socket.
We'll need 2 of these, please. That ought to do it. Front driver's side. We ran a bunch of tests. The journal bearing is completely worn out from oil starvation. Connecting rods aren't sending enough oil up into the pistons to prevent them from overheating. Piston number 4 detonated inside the cell, cracking the block, and coolant is now leaking into the cylinder. I'm sorry. I need you to sign here.
So this is a video that, as Kelly mentioned, we share with our students, and it always stimulates a lot of great discussion and insights. But I'm wondering, we wanted to kind of discuss with you, like, what do you think of that video, and how it may be like a metaphor for what sometimes happens in healthcare? Like, what things did you notice in that video?
This is Patty McClellan. As a nurse, I mean, I could see like poor communication, both verbally and written. There was no team communication during tasks. He seemed to be an assistant, didn't seem to be empowered to speak up when he saw something wrong. And those are just a few.
Yeah, great. Definitely. Like, so we noticed times in that where, you know, the lead mechanic was kind of mumbling, and it wasn't even clear that the the younger guy heard him or understood. Things were written down that weren't clear. Like, we noticed, like, the expression on his face doesn't seem like he seems like he's thinking of it. Has a question in his mind he wants to answer, but he doesn't ask that question. What other things did you guys pick up on in that metaphor?
This is Tisha Augustus. I'm also a nurse. What I noticed was that yes, it must have been a lead, and there was a hierarchy between the two mechanics. And the one that felt like they were in charge, that could have been considered a manager, didn't really care about what the assistant had to say or what they thought, which is often a problem in healthcare. Even though the assistant may have just started or doesn't have as much years of experience, uh, his experience inside the classroom could provide a little bit more insight, because as we all know, healthcare always changes, and that new graduate could have some new information that the older person does not know,
Yeah,
or has not even taken the time to research any kind of evidence-based articles to keep up on healthcare trends. So
that is that. Yeah, that is such a great point, Tisha. It just not only, like, a trainee, what trainees can offer to an environment and new information, or just somebody with a different perspective can offer, like, and if there's that hierarchy that you mentioned, that information can't really flow into the care. Gabriella also noted that each person was doing their own thing, right? So the roles were really rigid, right? Like, and there wasn't coordination between those roles or good communication. I think that's an excellent point. Other thoughts?
My name is Gail Talford. I'm with the Mecklenburg County Health Department. And what I noticed was there was no feedback to find
Mm,
out, did someone understand what was being communicated, not only with the technician and his lead, but also with the owner.
yes.
Clearly tell he didn't get an opportunity to ask, did he even understand what was being communicated? That was that total look of, did you just speak to me in another language because I didn't understand?
Yes. Yeah.
That's a huge part of communication, which also leads to miscommunication.
Oh, that's such a great point, Gail. I think you're exactly right. And it's so, like, apparent, like, at the very end, when the mechanic is talking to the owner, right? He's speaking in a completely different language. And I think that's one thing Kelly and I have really learned in our, or even gotten better in, is that each of our professions has our own jargon, right? And acronyms and shorthands, and the way we communicate with each other within a profession might be really different than how other won't have meanings for other professions. And so it's really, that feedback is critical, right? Like, we have to make sure that we're communicating in a language that's accessible to different people, and that back to the issue of hierarchy, when someone doesn't understand, can they ask, right, for clarification? Do they feel empowered to do that? Is the person who's speaking and communicating also being sensitive to whether, and checking out that their meanings are received? Any other last thoughts before we move on that that video sparked for you? Maybe something that you see in your own work environment? Okay, well, great. Well, I'll turn it back to Kelly. I don't know, Kelly, if you have any last comments or if you want to just pick up the PowerPoint.
Yeah, I'll resume the PowerPoint. We use this video just to hammer home the importance of team communication, but also communication with our patients and family members in our communities. Like, the ball bearings are shot. I'm sorry. Like, imagine being that patient. And we just love this video because it reaches any learners that we have in the class, whether it's nursing, social work, public health, health administration, health psychology. Everyone can relate to it probably because most of us don't know mechanic stuff. So we have no idea what they're saying. But that's our patients and our families and communities. Sometimes we forget that what their experience is all about, that they don't know the things we're saying. And it really, to us, speaks to the importance of team communication and then clear communication with our patients, our families, our communities. Pretty sure that man in that video will never take his car back. Even his next one, he had a bad experience. And so
Yeah.
now we're going to miss opportunities to improve his car, aka family members, health in the future. So
Yeah, and just to last point when you were talking, Kelly, I was thinking too about just the lack of empathy, because the other thing we see with the car owner, as we do with patients and families, is the distress and the fear and the anxiety that's happening for that person. And then there's nobody really attending to that part of the experience.
And not thinking about what that person's life is at home and the social factors going on there and the ripple effect. Like, okay, I'm sorry, sign this, you're done. And that's what happens in healthcare. We transition to one setting to another. It's like, okay, you're off my hands, you're on their hands, and they'll figure it out. And I don't know. I love the video. I hope you all enjoyed it. I'm going to share my PowerPoint again. There we go. Okay, so the solution, or a solution to all of those issues that we just talked about, errors that abounded in that video, hierarchical issues, lack of communication, not developing sound relationships with the patient, family, community. A solution to that is IPE, interprofessional education. Infusing IPE into our work settings can not only prepare future professionals for the workforce, but it can actually also improve practice among current professionals. What was talked about before, the things that our new graduates bring us, that our students bring us, that maybe we didn't get. I didn't get IPE as a student. And so I learned it through what our students are going through. And that's how we can infuse more interprofessional collaboration into our work sites, by using IPE as a tool to prepare our future colleagues, but also to improve the practices that we all have in our own work settings. So interprofessional education is not new. The World Health Organization defined it in 2010 as when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. And that's really important, that they have to learn about each other, they have to learn from each other, but then they also have to be immersed in learning with each other. That way, when they graduate, they've already learned about other professions, they've learned how to deal with conflicts, they've learned all of those things to prepare them to effectively just carry right over and employ those skills in their work setting that they're going to be in. While IPE is not new. I mean, 2010 is not new, but it is still relatively new, considering we've all been educating our, students for hundreds of years, right? So it is a relatively new approach. Really, a catalyst started like in the larger universities with affiliations with medical centers and those things. And now it's really, really growing, and it's really required by all of our accrediting bodies that we do some sort of interprofessional education, because we know we have a problem in our settings with implementing team-based care. And we know it's affecting our patients, our populations. We know that it's affecting our healthcare providers. So we need to get people prepared to work in teams. And we just wanted to share this quote from a really great article that really kind of compares sports teams to healthcare teams. And in that first paragraph of the quote on your screen, you can see that sports teams have an advantage of coming together over and over and over to practice together, to the point where whoever's catching the ball doesn't even need to look back. They know it's coming to them. They know what their teammate's going to do. They know what to expect. They know how to work together. They are in harmony. In healthcare, the barrier is that these desperate people come together on any given day, any given shift, any given hour. They're expected to work together. They may have never worked together. They may not know each other well, and they may not have each other's backs the same way because they haven't developed that trust, that sense of team. And that's what we see in healthcare. I mean, I can raise my hand and say that's what I've seen. I can't tell you how many times I responded to a patient emergency, or I sat in on a team meeting and I didn't know the other people. I didn't trust them. I wasn't going to really speak up as much, you know? So we see this difference in how other teams are really trained, and we're missing that opportunity. We really need to train our students, our providers, really to work together so that when the time comes and that any given situation comes, they're ready to go. They can fall into place as a team. Very, very important. So this is our third poll, and we want to know how much IPE you might have had. When you were a student, how often did you have IPE, which is learning with, immersive learning with students from other professions? Okay, so the results are there. So about half of you never had IPE, and the other half had a rarely or a handful of time, with one person getting to experience it more often, which is excellent. But you can see there, we didn't have IPE. Depending on when you went to school, I know for sure I never learned with students from other professions. And the effect that it had on me when I got out there, I cannot tell you how scared I was to communicate with others. I have to call a doctor. I have to find the social worker and discuss a case. What are they going to say? Are they going to think I'm stupid because I don't know what I'm saying the right things or not? So not having those experiences definitely disadvantaged me. Did I overcome that? Sure, I did. It took practice, but how many times was the potential there for error because I was timid to approach somebody else or get the help that I needed or look at something from a different perspective instead of my own profession's perspective. So never having had it, that fits a great majority of us in healthcare who've been in healthcare for a while. We didn't get exposed to it. Our students now are getting more exposed to it, but we need to increase that more so that it diffuses over into our practice settings and it becomes the norm, not an opportunity for IPE, the norm of IPE, the norm to learn amongst other individuals. We're gonna do one last poll here, if it lets me. And we want to know if you're seeing IPE currently being implemented at your own work setting. All right, so kind of all over the place. Some of your settings don't have learners. Some settings only have learners from one profession. And then others have immersed learning, but some they're not learning working together. So kind of all over the place. And really what we're going to work on after I'm done presenting the overview is Shanti's really going to work with us to brainstorm ideas of how we can get IPE being implemented more as a method to improve our learner outcomes, to improve our staff outcomes at the settings, our professionals outcomes, and how to improve the outcomes of our patients, our families, and our communities. So just a little background on IPE. The left-hand diagram, that's from the Institute of Medicine. And what I really wanted to point out on this diagram was the learning continuum in the upper left, that our foundational, our pre-licensure education, we need IPE, but then in graduate education, we need even more IPE. And then in continuing professional development of our healthcare professionals that are already out there working, we need even more IPE. So, you know, oftentimes you'll hear IPE talked about for our pre-profession learners, but really it's envisioned to really start there, but grow and continue into the workforce to learn how to continue to improve our practices working together. Why? Because, you know, as you move forward with your career, your responsibilities grow. You start to lead teams. You do all of these things that requires even more ability to perform the interprofessional competencies. But also because the further you get removed from doing IPE in school, and we see this with our graduate student learners, there's a need to revisit and kind of get rid of the way that we've been doing it and go back and reimagine the way that it can be done, to unlearn some of maybe the bad habits that we might have picked up along the way. And then the other thing on this diagram on the left-hand side is the bottom left part, the learning outcomes. This is something that we're going to dive into a little bit more in our discussion, because most of the IPE assesses learners at the level of attitudes or knowledge about each other, attitudes working together. But what we really need to move for, to know that IPE is being effective, to know that practice change can happen, that patient outcomes can improve, is we need to really be able to assess behaviors and performance in clinical settings. But we really need to be able to move IPE into those settings to be able to do such a thing. And then the bottom right-hand diagram is the IPEC interprofessional collaboration competencies. And there's 4 core competencies that I'm going to dive into in a second. But I wanted to really point out that throughout all of those competencies is the need to be patient and family centered, as well as community and population oriented. So IPE really needs to be in settings where people work with patients, with families, but also where they can work with populations. And that's where the public health settings really come into play. So the first competency is values and ethics. And this is learning how to work with individuals of other professions, because we all have different codes of ethics. We all have different values. We all learn differently. We all learn things from the context of our profession. And then we need to learn to respect that other people have different viewpoints, and that's okay. And that's what this competency is about, is really learning how to work together, really learning to value each other's opinions and develop those trusting relationships, but definitely to put the patient and or population at the center of the team. We have to stop delivering care to these patients' populations, and we need to start collaborating with them as part of our team to help make sure the care best meets their needs. The second competency is roles and responsibilities. And Shanti talked about this, you know, that we all come into things with different skills, different communication, different words that we use, different things. We need to learn about each other's roles. We need to learn about each other's responsibilities. We need to know about role overlap. All of our responsibilities keep it, you know, expanding. And so role overlap's going to be, you know, it's going to happen. It can be very positive because a lot of people are trained to do the same thing, but it can also lead to conflict. So it's learning about each other's roles, learning how to navigate that role overlap, and learning how to pull different roles and put them together into a team that can best meet the care of the patient, whether that be medical needs, mental health, social needs, being able to find the right individuals to complement the care that needs to be provided. The third competency is communication practices with patients, families, communities, and other persons on the team. This is interesting. In a lot of our discussion in our course about IPE, there's a lot of talk from the students about what you should and should not say and how you should communicate. very little talk on how you should listen. And so we really need to emphasize that active listening is a core part of communicating. We can't just be telling others what's going on, telling others what to do, telling others our thought without encouraging them to share their own. And that's the only way we get to shared decision making, is if everybody has a voice on the team and they are encouraged to use that voice. So you'll see in part 2, point 2 there, recognizing one's uniqueness, how your hierarchy or perceived hierarchy, your experience, your power, your culture, your gender, how all of those things can affect how you communicate and how others communicate to you, and whether it influences if they speak up to you or not, or they're scared to. And we really need to develop an understanding of that so that we can better encourage communication. This feeds into a point that was brought up before. It also includes providing feedback. Positive feedback for sure, we often leave that out, as well as constructive feedback and receiving that feedback as well. And then avoiding that jargon specific language as best we can, and clarifying it, looking at each other's face. Okay, I said a word they're not getting, let me clarify that, or they're comfortable to talk to me to clarify what I'm saying. It takes a while to develop that. When Shanti and I started working together, and we're peers, we worked together, she kept saying words, and I just remember thinking, oh my gosh, should I say something or not? And then eventually you say it, you get that practice, and you say, okay, I don't know, I do clinical experiences. What is this field? Like, where are you all? Just simple things like that. And now I'm comfortable to ask her things because I had that experience. So that's what IPE does. It gives you that comfort level. So then when you're out there, you're not timid to ask the questions. And then the fourth competency is teamwork and team-based practice. So relationship building values, principles of team dynamics. And this is to deliver and evaluate care as well as programs and policies. And it's really engaging other professionals in shared decision-making, shared problem solving. And that way you're all coming to a conclusion together of the best ways to proceed, less so delegating what needs to be done. And this is not to say delegation doesn't still need to be there, but more of a shared decision making and really being on it together. That's how people get invested, and we get new perspectives. And that's really how we move care forward, especially with the social determinants. This includes a lot of work on conflict resolution. We work on that a lot in our class. Conflict resolution, a lot of healthcare providers, especially from our two professions, tend to shy away from conflict. Well, most people don't love conflict, but more so sometimes we see it in nursing and in social work, not wanting to address conflict. But what we really try to get across is conflict can be good. It leads to new ideas, new ways of thinking about it, new ways of thinking about each other. But we do need to resolve it effectively. We cannot avoid it. So we teach them things from team steps, like the CUS acronym. I am concerned. This is unsafe. This is a safety issue. And, talking about that way, learning to address it in a way that I feel, instead of you're doing this. Learning to avoid confrontational behaviors and reserve that, really address that conflict in a positive way so the team can grow from it. So how do we master these competencies in our students, and then, also our healthcare providers that are already out there? The first step is interprofessional exposure, hearing each other's stories, learning examples, doing interviews of other professions, just learning about each other. And then we move to dialoguing with each other, where we explain our role. We have other people explain their role. We clarify things with each other. We compare, we contrast. And then we move into teamwork, where we can do case studies, group discussions, and we can even move into teamwork that is simulation based. And that's where most of the work that we've been doing in our online class focuses on. They are exposed, they dialogue, and they do teamwork because we filmed video simulations for them to plan the care of patients, families, and communities using these video simulations. We also do simulations in our laboratory setting. I'm involved in one for the Bachelor of Science in Nursing students, and they use telehealth, iPads, basically FaceTime, to reach out to other professionals to get their insight about how to care for a patient need. One of them needs respiratory therapy, another needs social work, and so forth. And so there's different ways to get that going, but we really need to move IPE more into community settings, more into practice settings, so that they can actually practice team-based care of patients and populations. And you can see that star there. Really, we want them to be able to practice complex team-based care, really learning how to address complex patients with issues with social determinants of health. And one thing that we have been involved in is something called healthcare hotspotting. And we do this with colleagues of ours from medicine, pharmacy, of course, nursing and social work, and I'm probably forgetting health psychology, several professions that we collaborate with at Atrium Health. And the small interprofessional student teams get these super utilizer patients that have frequent ER visits, frequent admissions, chronic diseases, multiple comorbidities, and social determinants that need to be addressed. And they work together and they address these things together in a team-based approach. They go visit the patient's home. They see what they need. Oh, they're not going to their visits. It's because they don't have transportation or whatever it may be. So we'd really love to see opportunities like that grow, where these students, they get so much value from really seeing how each other can contribute. And it just really makes a big difference in their learning. And our published results show improved patient outcomes from a utilization standpoint, less ED visits, more visits to their primary provider, and lower costs go with that. So we know that this involving our students in complex care in immersed team-based learning can really improve outcomes for our patients, for our communities, and we learn from it too. So we just continue to share new things. We just want to share from our class student feedback that just really stood out. It may seem easier or at least tempting to just do the work by yourself, which it does, right? We can all probably attest that. But it is worth the investment of time and patience to synergistically create a more well-rounded plan. And another wrote, collaborating on group projects showed the richness that sharing the work, not just dividing it up, can bring. And this requires coaching on our part. Mentorship throughout IPE is vital. We really need to, because their first inclination is, okay, there's 8 questions on this assignment. You take 1 and 2. I'll take 3 and 4. They'll take 5 and 6. And they divide it up that way. And when we get the work, we can totally tell, okay, this only came from a social work's point of view. This only came from nursing's point of view. This only came, you can tell where it's coming from. And then we just remind them, okay, now review each other's work, add to it, collaborate, do things together. And the products that come back, just so much more expansive, more comprehensive, and much more practical. You could tell it can really approach the problems that the group project was meant to design. So we really, really love those quotes the students brought forth. Whew. All right. I just have, I think, 2 more slides here, and then we're going to have some group discussion. Just the benefits of IPE. It benefits our learners. They get exposure to teamwork, team processes before they get out there and practice. They can refine their skills. And it also provides insight on other career options for those that might be going on to further their education. It benefits our clients, whatever our clients are. They have access to multiple disciplines, different ways of thinking, different approaches, different resources. They have a dedicated team. They get comprehensive care, and they get creative problem solving. Really infuses that creativity into what we can do. And it benefits our current healthcare professionals and the workplace, infusion of new ideas, new approaches, a renewed focus and passion for team-based care. And it can give recognition of mentoring benefits. So the value is clear. We know there's value to doing IPE. Why aren't we doing it more? One of the biggest barriers is in anything change. This is the way we've always done it. This is how we do it. This is what I went through, so you should do the same thing too. And we really need to move away from that focus. We really need to embrace new ways of doing it and recognize that, you know, what we learned, how we learned, yes, it was good, but maybe there's other things we can do that would make it even better. Other barriers are getting faculty and healthcare staff buy-in to work with our interprofessional learners. It can be time intensive for faculty, arranging large groups of different interprofessional students to come together, getting buy-in from staff, working with interprofessional learners, because it pushes you outside your comfort zone. It did for me, teaching social work students. I don't know social work. I mean, I know a lot of social workers and I've picked up some over the time, but it pushed me out of my comfort zone, mentoring them as well as my nursing students. And so it does, it pushes you out of your comfort zone, and you have to have buy-in for people wanting to do this, but it is so worth it. We have policies and procedures in place that inhibit IPE. Conflicting scheduling, that to me is one of the biggest ones. Oh, we'd love to do IPE, but we're only available on this day at this time. Well, my students are here at this day, this time. So we see a lot of confliction there. We also see it in our healthcare settings. We would love to send students to this clinic. Oh, well, it's only open on Tuesdays. Okay, so we can't do that. So we see scheduling issues. We have a need for logistical support, someone to help with this scheduling. It's not an easy feat. So having somebody to help with placing students, figuring out the settings where they can take more students, what professions, those types of things. And then lack of preceptors and mentors on site. Some of our disciplines require certain credentials, certain training from discipline specific mentors. So making sure that the site meets what we're required to do, that type of thing. The picture on the right hand of the screen, and we sent this out as a resource if you're interested in reading it in your fun time. This came out in 2019 to overcome these barriers. All of our health professions came together, Council on Social Work, American Association of Colleges of Nursing, all of them came together and developed guidance on IPE to show that it is coming from all of us. We can all work together to overcome these barriers. So we know that the advantages are there. We know that there are barriers. So what we want to work on now is figuring out how do we get IPE better going in our practice sites to benefit our learners and to benefit our healthcare professionals that are working there. And the quote, I'm going to end you with this, I'm going to turn it over to Dr. Kulkarni, but the quote in the upper right, if we are to have a stable, socially based, efficient, and safe health system, it is necessary for all of us, healthcare workers, policymakers, and educators, to implement IPE and collaboration at all levels of our healthcare system. It's vital to meet the needs of our complex patients, our complex problems in society. To address them, we really need to have an interprofessional approach.